Hello, hello. Hello, good evening, and welcome to Moving Forward and the new and improved speaker system that everyone should be able to hear tonight. So anyway, I'm here and it's my honor to introduce Dr. Suzanne Seeger. She is a physician at the UW Health Neurology Clinic and part of the memory care clinic that we have there as well. So tonight she's talking about memory loss, and I will let her get started.
Thank you very much, and I hope you can hear me also. If I'm too loud or too soft, you just let me know, and I'll try to do something about it. I am very honored to be here. Thank you very much for inviting me, and it's a great honor to speak to this support group because it's a well-known support group. It's probably the best movement disorder support group in the Midwest, so I'm glad to be here. I was asked to talk about memory loss. Is it normal aging or dementia? And when you look at papers or at books, people always make some jokes about memory loss and take it somewhat lightly. There's a lot of cartoons about it, but in reality, dementia is not really funny. The most common cause of dementia is Alzheimer's disease, and there are almost 6 million Americans who have Alzheimer's disease in the year 2019. That's more people than inhabitants in Wisconsin. It's estimated that by the year 2050, about 14 million Americans will have Alzheimer's disease, so that's more than double the number. And it has become the 6th leading cause of death, and it is very costly. This year alone, it will cost the American economy about $290 billion. By the year 2050, it's estimated to be $1.1 trillion. And why are we talking about this? The reason is that we're all getting older. Memory loss is predominantly a problem of the elderly. In the year 2010, there were 40 million Americans who were over the age of 65. By 2050, there will be more than twice as many Americans who are over the age of 65. And not only are we getting older, but even older people are getting older. In the year 1960, which is right around the time I was born, hardly anybody was older than 85. But now in the year 2020, which we are almost at, there is a sizable number of people who are over the age of 85, and even if you look ahead, the number of people over the age of 85 will continue to grow. And this is why memory loss, dementia, Alzheimer's disease is becoming a growing problem. And it all sounds very depressing, but it's not totally depressing. We have actually found that new cases of dementia have started to decline a little bit. This was a study that was done in Germany and in the United States, but it's probably the case for other countries in the Western world. This was most noticeable in women and most noticeable in those with at least high school education. And the reason is that over the years, education improved, especially for girls, and we're doing a better job controlling blood pressure and cholesterol. People smoke less and are overall healthier. And indeed, this has not only resulted in fewer heart attacks and fewer strokes, but also in fewer new cases of Alzheimer's disease. And that raises the question, is dementia really preventable? There was a fairly recent observational study that speculated that about 35% of dementia might be attributable to modifiable risk factors. That means about a third of dementia cases might have been prevented one way or another. For example, 8% of dementia could be attributable to limited education in early life. That means no education or primary school only. So if everybody goes to school, gets an adequate education, this may decrease the risk of dementia by about 8%. 12% of dementia cases are thought to be attributable to health factors in middle life, and especially hearing loss, high blood pressure, and obesity seem to be playing a role. So if everybody who has hearing loss got their hearing loss treated, if high blood pressure was properly controlled, that could also decrease the risk of dementia. And even later on in life, when people are over the age of 65, there are still some cases of dementia that can be prevented by reducing smoking, by treating depression, by becoming physically active, preventing social isolation, and treating diabetes aggressively. So there's a number of things one can do on the public health side that might reduce the risk of dementia. So just getting old, of course, is a risk factor, but you can still do something about it to make it less likely. So let's talk a little bit about memory. We always say, oh, I have a poor memory or forgot, and we use that term a lot, but we have to define it first. What really is memory? Memory is the ability to recall stored information from the recent or distant past. That means this is something we have to learn first, and then we can remember it. And to make things more complicated, there's different types of memory. And this looks like a very complicated slide, and I don't expect you to understand this immediately, but we'll walk through it step by step. So we start by looking at short-term memory and long-term memory. Short-term memory is what you're remembering from a few hours ago or from a few days ago. Long-term memory is something that you remember for a much longer period of time. So short-term memory is also called working memory because it allows you to go through your daily life. One example is you're getting a phone call from your daughter and she says, I'm going to come over for dinner on Sunday night. Then you hang up the phone, you walk over to your calendar and write down on the calendar that your daughter is coming over for dinner on Sunday night. And that period of time that you remembered what she told you until you wrote it down on the calendar, you used your short-term memory for this. Another example is you're sitting inside reading the paper, your husband is outside mowing the lawn, and you read something very interesting in the paper. And then you remember it long enough until your husband comes back inside so you can share it with him. That is called short-term memory or working memory. You can also turn your short-term memory into long-term memory. Sometimes you forget it because it's not important, but sometimes you want to remember it long-term. And for that, you use a part of the brain that's called the hippocampus. And the hippocampus is a small part on the inside of the brain that is shaped like a seahorse. And hippocampus is a Greek word for seahorse, so it kind of looks cute. And people who first discovered the hippocampus thought it looked like a cute seahorse, and that's how it got its name. So when you read about memory loss or dementia or Alzheimer's disease, you'll read a lot about the hippocampus. So that was the short-term memory that we just talked about. Let's talk about long-term memory. Long-term memory means that you store the information for a longer period of time so you can recall it later. And you may remember it for days or for weeks or for years or lifelong. You probably all remember the name of your first grade teacher. You remember the name of your best friend when you were a little kid. You probably remember the name of your neighborhood bully. Those are all things that you remember with your long-term memory. And there's not just one spot in the brain where the long-term memory is stored. It's really widespread in different parts of the brain. There's different types of long-term memory. One is called, hold on, let me just go back. I think I jumped too far ahead. There's different types of long-term memory. There's explicit memory and implicit memory. Explicit memory is all the things that you remember that you can put into words, that you can talk about. For example, what did I have for dinner? You can talk about this. Where did we go on vacation last year? You can talk about this. When did we move to Madison? You probably, if you live in Madison, you probably have an answer for that too, in your own words. And then there is semantic memory. That's the stuff that you learn in school. You do not know that automatically, like when you move to Madison. Semantic memory is stuff that you have to learn first. So pretty much all the stuff that people told you in school, the names of US states, the names of trees and flowers and sports teams, and all the things that you care to memorize throughout your life. And then there is another type of long-term memory that's called implicit memory. So we talked about explicit memory, now we're talking about implicit memory. Implicit memory is stuff that you cannot put into words. That's stuff that you know, but you would not normally talk about it or say it. So for example, if you listen to music a lot and then you hear the first few notes of that song, you know the rest of the song automatically. That's called implicit memory or priming. So things that you know just from hearing a snippet of it. Or you look at part of a picture and you've seen that picture before and immediately you'll know what else is on the picture. And then there's also something else that's called procedural memory. That's also stuff that you don't need to talk, that you don't need to put in words. Usually stuff that you learned as a child, how to brush your teeth, how to comb your hair, how to drive a car, or how to ride a bike. So that is all called implicit memory. So different types of memory, and they can all be affected differently at different stages in your life. So then that brings up the question, is it normal that we lose memory as we get older? And the answer is yes. It's pretty normal to lose memory as we get older, but not always. So we'll talk about what kind of memory loss is normal and what isn't. So normal aging includes all kinds of things that happen to us as we get older. We get smaller, we walk slower, we have more joint pain. So that's all part of normal aging. But also our memory, our long-term memory declines with age. And if we want to learn something new, if we want to memorize something, it just takes us a little bit longer. We also get slower in remembering things. We know something, but if somebody asks us about it, it still takes a little bit longer until we can come up with the answer. When somebody talks to us really fast, it takes us a little bit longer to figure out what people are really saying. It's harder to multitask. That's another part of normal aging. And I hope that makes you feel good. It starts at age 20. So even somebody in their 20s is already starting to have some degree of declining memory. And between the ages of 20 and 60, the memory declines rather slowly and very gradual. But after age 60, the memory decline is a bit more rapid. And some of us in the room are over the age of 60, so we all know all about it. So how can we now tell whether the memory loss is part of normal aging or whether the memory loss is somewhat more concerning, whether the memory loss is now a sign of dementia? So there are some examples. So it is normal to make a bad decision once in a while. Last week, for example, I thought, well, we don't really need to mow the lawn just yet. It's not quite high enough. But then it rained so much by the time we got around to do it, it was way too high. That was a bad decision, right? Making that decision once in a while, that's quite all right. But showing consistently poor judgment and difficult decision making is maybe a sign of dementia. Missing a monthly payment when we pay our bills, well, that can happen to everybody. Once in a while, you just forget or you lose the envelope. But the inability to manage finances, to manage larger sums of money, to keep track of your budget, that could be a sign of dementia. It happens to all of us, especially when we're on vacation or retired. We just forget what day of the week it is. But if we think about it, we eventually will come up with the right answer. But completely losing track of the day or the season or not knowing what time of the year it is, that can be a sign of dementia. Sometimes we just can't think of the right word. And we just cannot come up with the right word, or we find the wrong word. That can be part of normal aging. But if we get to a point where we cannot hold on to a conversation and cannot speak in complete sentences, that could be a sign of dementia. Everybody loses things once in a while, but misplacing or losing things frequently could be a sign of dementia as well. So when somebody gets older and eventually develops dementia, we don't really go overnight from normal aging into dementia. It's really a very gradual process. And before somebody develops dementia, there's usually a stage before that that's called mild cognitive impairment, or MCI for short. Both people who have mild cognitive impairment or dementia have difficulties with thinking and with their memory. But people who have mild cognitive impairment are still quite independent. There is no significant impact on their daily activities or on their independence. But people who have dementia have such severe difficulties with thinking or memory that it does affect their daily activities and their independence, and they usually need somebody who keeps an eye out for them. So let's talk about mild cognitive impairment just a little bit more. As I said earlier, people who have mild cognitive impairment have difficulties with memory and thinking. They have trouble concentrating. They may have trouble coming up with the right words pretty consistently. They may forget appointments. They may forget what time it is. But they are usually able to care for themselves and for their household, and they're usually still able to drive. Most people who have mild cognitive impairment may eventually develop dementia, but not everybody does. The risk, though, is pretty high. So 10 to 15% of patients with mild cognitive impairment will develop dementia per year. So somebody who has mild cognitive impairment has a 10 to 15% risk of developing dementia over the course of the next year. And if you look at a longer period of time of 6 years, 80% of patients with mild cognitive impairment will eventually have developed dementia. And that's pretty widespread. About 10 to 20% of people over the age of 65 have mild cognitive impairment. So this is quite common, but still people live quite independently. They just need to be watched a little bit more carefully. So now let's talk about dementia. And I just want to give you a few more examples of what kind of things may happen when somebody has dementia. And now the so-called 10 warning signs of dementia. As I said earlier, memory loss is definitely a sign of dementia. Forgetting recently learned information, forgetting dates and times, asking the same questions over and over again, and relying on others to keep track of things. That is definitely, can be a sign of dementia. Somebody with dementia may also have greater difficulties planning and solving problems. Following a recipe may become more difficult. Writing down the right numbers when writing a check or balancing a checkbook may become more challenging. It's just overall harder to concentrate, and if the person is able to do something, it may just take them a little bit longer. Another sign of dementia could be difficulties completing a familiar task. For example, not being able to drive to familiar places, getting lost, getting somewhere that should be familiar, difficulties remembering the rules of a game that somebody has played since they were young adults, or difficulties remembering certain tasks at work if that person is still employed. Another sign of dementia could be confusion with time or place. Somebody's losing track of dates and times or the season. As I said earlier, that can sometimes happen to all of us. We wake up in the morning, we just can't remember what day it is. But we usually, if we just think about it, will eventually come up with the right answer. But somebody who has dementia may just not figure out anymore what day or what month it is. Another sign could be forgetting how you got where you are and forgetting where you are. Somebody might be in the mall and then completely forget how to get home and completely forget how they got there. Another sign could be some changes in interpreting what you're seeing. So looking at something written might not make sense anymore. It is harder to judge distances. It's harder to interpret colors and different contrasts in a picture. And in extreme cases, a person with advanced dementia might not even recognize himself or herself anymore in the mirror. Dementia can also affect speech and language. It's becoming harder to join conversations or following conversations. It is harder to complete sentences, harder to come up with the right words or using the wrong words. Misplacing things, remember I said earlier, it's normal for all of us to misplace things, but misplacing things consistently and not being able to find it again, that can be a sign of dementia. And sometimes that also leads to the person accusing others of stealing, because if you've misplaced it and you don't really know that you did misplace it and you can't find it anymore, you might think somebody else took it from you. Somebody who has memory problems or difficulties following conversations might also become more withdrawn because the person becomes more self-conscious about their memory or about their speech. They may stop participating in activities that they previously liked, and they may even withdraw from friends and family. Some patients with dementia also have changes in their personality. They become more confused, they might be depressed, they might become more anxious and fearful and suspicious, and they are suddenly not the person anymore that they used to be. They can also become easily upset when they're outside of their comfort zone. And the 10th sign of possible dementia is decreased or poor judgment. And that's particularly worrisome when that person is dealing with money, because some patients who have developed dementia have given away large sums of money or have fallen prey to telemarketers or other people who cheat on the phone. And another sign may be less attention to grooming or to personal hygiene. So those are all possible signs of dementia, but just remember, a milder version of all of those signs might still be normal to a degree. So there's different types of dementia, and often Alzheimer's disease and dementia is used interchangeably. Not everybody with dementia has Alzheimer's disease, though, but Alzheimer's disease is definitely the most common type of dementia. There's another type of dementia that's called vascular dementia, so we'll talk about that in a moment. There's dementia with Lewy bodies. People who have Parkinson's disease can eventually develop dementia. And then there's another interesting type of dementia that's called frontotemporal dementia. And those are just a few examples of what types of dementia we have. There are many others that we will not go into in the interest of time. So let's briefly talk about Alzheimer's disease. There's probably nobody in the room who has not heard about this yet. This is the most common form of dementia. About 60 to 80% of all patients with dementia have Alzheimer's disease. We said a little bit earlier, the biggest risk factor is age. We're all getting older, and the likelihood that we develop dementia or Alzheimer's disease as we get older gets higher. Up to 50% of the population over the age of 85 has Alzheimer's disease. So it is really a disease of the aging brain. It can occur at a younger age too, but only 5% of Alzheimer's cases occur under the age of 65. Another big risk factor is family history. If somebody has at least one relative or several relatives with Alzheimer's disease, the likelihood that they will develop Alzheimer's disease is also increased. What really happens in the brain when somebody has Alzheimer's disease? I'm not going to give you an anatomy lecture or pathology lecture. That would probably last way too long. But the most important thing to remember and take away from it is that whatever happens in the brain starts as early as 20 years before we even notice the first symptoms. So that is really discouraging and alarming, because by the time we do have signs of dementia, it means that a lot of things have already happened in the brain. As we said earlier, the most common symptom is forgetfulness, but the other signs of dementia that we just talked about may develop at a later point. There are different stages of Alzheimer's disease. That's a question we very often get in the memory clinic. So what stage of Alzheimer's disease do I have? And there are different ways of staging this. In research, we use those 3 stages. There is the preclinical stage of Alzheimer's disease. That's when the brain shows signs of Alzheimer's disease, but on the outside, we don't know about it. Then there is the mild cognitive impairment that we just talked about. And then the 3rd stage is dementia related to Alzheimer's disease. You will also sometimes see 7 stages of Alzheimer's disease. That is now less commonly used. But again, stage 1 would be no impairment, stage 7 would be the most severe impairment, and everything else in between is a little bit less severe. So this is just one picture of a brain under the microscope when Alzheimer's disease has developed. The nerve cells in the brain are lost, and then you can see that there are kind of holes in the brain. And then there's also certain protein fibers that are deposited in the brain. And if you ever read about Alzheimer's disease, if this interests you, and you read a little bit more about the research in Alzheimer's disease, you'll come across words like beta amyloid and neurofibrillary tangles. So those are the buzzwords that researchers use when they look at the brain of a person with Alzheimer's disease. Another type of dementia is called vascular dementia. And that type of dementia is caused by little strokes. So when blood vessels are blocked, or when people have little strokes, like these white spots everywhere in the brain, the nerve cells can't communicate very well with each other anymore, and they may also die off because there's not enough oxygen coming anymore. So that's what we call vascular dementia. It may look like Alzheimer's disease, but somebody who has vascular dementia usually declines a little differently. A patient with Alzheimer's disease will kind of have a slow, gradual decline, versus somebody who has vascular dementia will stay stable for a long time, then they have another stroke, and then they decline, and then they stay stable for a while, and then they decline. So it's a little different disease course. Vascular dementia is probably the most common type of dementia, and the older somebody gets, the more likely it is present. It's also more likely going to be present in somebody who has high blood pressure or diabetes. Because it's also a disease of the elderly, it may actually coexist with Alzheimer's disease, so it's not uncommon that somebody has Alzheimer's disease and vascular dementia. Another condition that can lead to dementia is called dementia with Lewy bodies. That's considered the 3rd most common type of dementia. These patients will have problems with their memory or thinking, but they also develop other symptoms that look like Parkinson's disease. So it's almost like a mixture of Alzheimer's disease and Parkinson's disease. And it can be hard to tell it apart from somebody who has Parkinson's disease. There's a few things that are a little different, though. The patient who has dementia of Lewy bodies will have very strong fluctuations in their alertness and in their day-to-day functioning. They may have one day where they look like they're on top of their game, and the next day they're very impaired. And then they may have yet another couple of days where they look very well, and then they have another day where they're very impaired. So this is very common in patients of dementia of Lewy bodies. But they also do develop symptoms of Parkinson's disease, like the tremor and the stiffness and the balance problems. Patients of dementia of Lewy bodies will also often develop visual hallucinations where they see something or perceive something that is not really there. Another symptom that patients who have dementia of Lewy bodies and Parkinson's patients often have is a certain type of sleep disorder where they act out their dreams. You may have had lectures by somebody from the sleep clinic here who talked a little bit about that. So it's a very interesting sleep disorder. It can be very disruptive, but it can definitely be treated. As I said earlier, patients who have Parkinson's disease can develop dementia, and this is usually something that occurs late in the disease. It's usually not something that happens early on. So how can you really tell the difference between Parkinson's disease-related dementia and dementia with Lewy bodies? Somebody who has Parkinson's disease will develop the movement disorder first, without anything else going on. But somebody who has dementia with Lewy bodies will develop the movement disorder and the memory problems within the same year. So they usually occur at the same time, or at least within 1 year. In patients with Parkinson's disease, the memory problems develop more than 1 year later, usually many years or even decades later. The hallucinations that we just talked about are less common in patients that have Parkinson's disease and much more common in patients with dementia of Lewy bodies. And also those fluctuations from day to day, where somebody is really looking good some days and then not at all the next day, is much less common in Parkinson's disease than in somebody who has dementia with Lewy bodies. One other type of dementia I wanted to mention, you may hear about it or read about it, is called frontotemporal dementia. And I have a picture of the brain here on the right side of this slide that shows you the different parts of the brain. So the frontal lobe is right here, that's in the front of the brain, obviously, and the temporal lobe on the side of the brain. And patients who have frontotemporal dementia have difficulties with the frontal lobe and the temporal lobe. They may have some changes in their behavior, or they may have some changes in their speech, but their memory may still be pretty good. It is rare, or rarer than Alzheimer's disease, only about 10 or 15% of all dementia cases. But if you look at somebody under the age of 65, it is much more common. Remember, Alzheimer's disease is something that people experience past the age of 65, especially over the age of 85, but frontotemporal dementia is much more common in the younger population. There's different types of frontotemporal dementia. The most disturbing one is called behavioral variant frontotemporal dementia, and people have very profound personality changes, and they truly become almost a different person, which is very difficult to deal with for their family. They exhibit reckless and socially inappropriate behavior. Some of those behavior changes can occur in the late stages of all other types of dementia, but when it comes to frontotemporal dementia, it's the first symptom that occurs. And there is usually not much memory impairment, so it's sometimes hard to recognize, and some people may actually be diagnosed with a mental illness, with depression, or some type of bipolar disorder, when in fact they do have frontotemporal dementia. Another type of frontotemporal dementia is called primary progressive aphasia, where people progressively lose the ability to produce speech, to say something, or to understand it. They speak with very short sentences, one-word sentences, but the memory is still pretty good. So it's a very interesting type of dementia, and again, it is one that predominantly occurs in people under the age of 65. As I said earlier, there's many other types of dementia. We're not going to have time to talk about those, but one that I wanted to point out to you is the dementia related to athletic activities, because we read about it in the paper all the time, especially boxers, but also football players have developed early types of dementia that can be very devastating and are usually associated with behavioral changes as well. There's another condition called normal pressure hydrocephalus that I will not talk much about, but it's always something we look for. And then alcoholism and many other conditions can cause dementia. So one question we get very often in our clinic is, well, is this going to go away? Unfortunately, most of the time the answer is going to be no, but we'll always make every effort to look for causes of dementia that we can treat. And if we identify something we can treat, sometimes that kind of dementia can go away. So there are some examples. Somebody who's very, very depressed, very isolated and depressed, may look like he or she has dementia, but if you treat the depression and if you reverse the isolation, they may actually do much better again with their memory. When the thyroid gland is not working well, you can develop dementia, or at least significant memory problems, severe anemia, vitamin deficiencies, and the most important one is the vitamin B12. As we get older, it is much harder to absorb the vitamin B12 from our food. And if the vitamin B12 level gets really low, then somebody can develop significant memory problems. One other thing we always look for is medications. There are medications that may make somebody look like they have dementia, and the most common ones that we identify are pain medications, especially the narcotic pain medications or sleep medications. You can imagine something that puts you to sleep at night may also still make your brain function a little bit less during the day. And there are sleep medications that you can get prescribed by your doctor, but some people buy stuff over the counter, like Unisom and Benadryl, and those medications can make it very, very hard to think straight during the day. So no Benadryl and no Unisom at night, because it can give you significant memory problems. Some people have sleep apnea that is either not recognized or not treated. And it also makes it very difficult to think during the day and to remember during the day. So somebody who has sleep apnea should be treated for it, because it can actually improve the cognitive function and their memory. So, as Addie said earlier, I work in the memory clinic at UW, and we see several patients each week who come in and are concerned about their memory, that they are concerned or their family is concerned. And what is it that we do to figure things out? We start by talking a lot. We ask a lot of questions, and that's about 80% of the visit, where we really need to know a lot of things about somebody's educational background, about somebody's work, about somebody's day-to-day activity. And we also do a physical exam and a neurological exam, and the biggest part of it is the mental status examination, where the person has to memorize things and reproduce it, draw pictures and name pictures and so on. And then just to make sure we're not missing anything that can be treated and reversed, we do some blood tests and we do some brain scans. Normally, when we do this kind of testing, we will be able to tell afterwards whether the memory problems are related to normal aging, to mild cognitive impairment, which is kind of an intermediate stage, or related to dementia. And then we may do even more testing to figure out what is causing the dementia. And that is usually done by somebody who specializes in memory disorders, and that may include an MRI scan or a PET scan. Sometimes we even do a spinal tap and look for certain proteins in the spinal fluid to help us make a diagnosis. And then the next question, of course, is always, so what do we do about it? Now somebody has Alzheimer's disease, how can we fix this? And unfortunately, even in the 21st century, we still don't have anything to fix this, which is very unfortunate. We do not have a cure yet. Of course, there's a lot of research going on, and we're trying to figure something out, but I think most of us in the room, including myself, may not benefit from it anymore, but I hope our kids and our grandkids will eventually have the benefits from all this research that is going on. There are several medications that are FDA approved for Alzheimer's disease, and I'll show those to you in a moment. They are not going to fix Alzheimer's disease, but they can slow down the progression of the disease, and this is very important because it may give this person just more years where they're functioning at a reasonable level. There are some other treatments that we'll get to in a moment as well. So these are the medications that are currently FDA approved for dementia and particularly for Alzheimer's disease. You may have seen advertisement for it, especially for the Aricept. There's a lot of ads out there. Others are called rivastigmine, galantamine, and memantine. So I don't expect you to memorize this, but I just wanted to show you some of the names in case you recognize them. There's also a lot of organizations and other doctors and pharmacies and so on who are trying to sell you stuff that's usually very expensive, and they tell you that this will reverse Alzheimer's disease and that this will fix you, and none of that has really ever been proven. So none of those supplements and hormones and compounds have been FDA approved. If you choose to try one of those, you can certainly do that, but don't ever do this without talking to your personal doctor first, because even things that are considered natural and safe may not be all that safe and may not all be natural, and they can be harmful or may even interact with some of the other medications. So just because something is not, something does not need a prescription does not mean it's perfectly safe to take. So here's some of the examples of what has been, what has been recommended. Certain types of vitamins. Vitamin E has been pretty much debunked. It probably doesn't do anything for the memory, but B vitamins may, especially the vitamin B12. Estrogen replacement has fallen out of favor. We did this for a while, and then we figured out that it doesn't really do very much. There are some anti-inflammatory medications like aspirin and naproxen that have been tried in reducing the effects of dementia and particularly of Alzheimer's disease, but that's not a good idea to take naproxen, which is the Aleve, every day. Ginkgo biloba was also sold for a lot of money, probably doesn't do anything at all. Some people use statins or cholesterol drugs for a good reason, but if it's only taken for memory problems, it probably isn't a good enough reason. Others take omega-3 fatty acids. It's probably pretty harmless, but it's still not determined whether it actually does anything good for the brain. What we do know, though, is that lifestyle plays a big role. Even if somebody has already developed dementia, we can still do a lot of things to improve the functional status. And the one thing that has really been shown repeatedly in several studies to be really beneficial for the cognitive function, for the memory, is physical activity. It doesn't mean that somebody has to go out now and sign up for classes at the gym and has to push weights every day, but things as simple as going for a walk for half an hour every day, or even longer if it's possible, can make a huge difference in the brain function. So this is always something that can improve the cognitive function in anybody at any stage. Also, prevention of social isolation is crucial. Being socially active, coming to a support group, meeting with somebody for a game, baking a cake with somebody, getting together with your grandkids is incredibly important in maintaining and or even improving the brain function. Also, regular mental activity. We always talk about the crossword puzzle, Sudoku. If you don't like it, don't do it, but do something different then. Read a book, try to memorize a poem, or learn a new song, learn a new game, and keep up with your hobbies if you have one. do it. If you don't have one, find one. All of those things are very important to maintain the brain in good shape. So the bottom line is the healthier you are, the healthier your brain is going to be. And this will then also slow down the progression of any kind of memory disorder. Other things that need to be done is limiting or eliminating alcohol use, absolutely no smoking, getting 7 to 8 hours of sleep every night. Right now in 2019, we're saying that the Mediterranean diet is the best for you. I bet this is going to change many more times over the years, but right now we all think the Mediterranean diet is the best for you. If there's hearing impairment, it should be treated. If you can't hear very well, you cannot understand very well, you're not going to remember anything, and it also leads to additional social isolation, so hearing impairment has to be treated. And the same is true for high blood pressure. Sometimes we let the blood pressure ride a little bit higher if somebody has never had a heart attack or stroke, but if there is a memory concern, the blood pressure should be kept at a lower level because it also protects the brain. So, is there anything in the future that gives us hope? There's a lot of research going on. If you're interested in clinical trials for yourself or somebody you know, there's different places where you can search for clinical trials in your area. There's the Alzheimer's Association Trial Match. You can go to a website that's called clinicaltrials.gov. And then there's also the Wisconsin Alzheimer's Disease Research Center, which is right here at UW. And if you need help, there's some places where you can turn to. There's the Alzheimer's Association of South Central Wisconsin and the Alzheimer's and Dementia Alliance of Wisconsin with their website and their phone numbers. And that's what I have for you, and I'd be happy to answer any questions that you have. Correspondence in terms of that one increases the risk of the other? Not that I know of. The only thing that increases the risk of having both is getting older, because both Parkinson's disease, or the risk for Parkinson's disease, is higher in the elderly, and Alzheimer's disease occurs more commonly in the elderly. There's one condition, as I said, that almost has both of them combined. That's the dementia with Lewy bodies. That also can occur in the elderly.
Thank you. I don't know if you need that.
You may not.
I enjoyed your presentation. There was one slide I took exception to. You have a light blue background with white letters. I have compromised eyesight, and I find that troublesome to read.
Okay, well, thank you for the feedback.
Overall, I enjoyed it well.
Yep.
Thank you.
Thank you.
Any other questions?
Somebody back there?
As we age, there's a good bit of dental problems too. And I was recently at the dentist's office, and they, not knowing I had Parkinson's, were saying that periodontal disease, I think it's called, gum disease, they're starting to suspect can have a role in terms of Parkinson's or Alzheimer's, and there's research going on in that regard. Do you know anything about that? Is it true?
So let me just repeat the question so that everybody can hear it. So is there any connection between gum disease and Parkinson's disease and Alzheimer's disease? It's possible, although again, gum disease is something that occurs in the elderly. There have also been studies that show that gum disease increases the risk of heart attacks and of strokes. So in either case, it's good to get it treated or not to get it in the first place.
So my question is about medication forms and adherence to medication. like Aricept or any of those types of medications, is the patch a good option? Is there a patch form, and is that a good option for people who often struggle with taking their medication?
Right. Good question. So do those medications that I have listed here come in a different form, in patch form? The Donepezil or Aricept doesn't, but rivastigmine does. And I think some of them come in liquid form. I don't think, though, that the Donepezil comes in liquid form.
Do you find that the patch is better for adherence? Or do you have a specific drug that you think is more easily adhered to, or just does it vary?
It's a good question. So usually when you put a patch on somebody for 3 days, it's easier to adhere to that. But also the other advantage of the patch is that it has fewer side effects. Sometimes the oral preparation of those first 3 drugs can cause some nausea and diarrhea. If you use it as a patch, if you use the rivastigmine patch, it's better tolerated. So that also increases the chance of adherence.
Okay, we have a question over here.
Hi, I was wondering, do you have that stuff written down somewhere so we could take it home?
Yes, so
That would be a question for Addie.
yeah, so we don't have handouts, but we do have online. If you go to uwhealth.org/moving forward, you will see that it takes you to this video presentation, but it'll have the slides with it as well. Okay? You're welcome.
Is that Exelon patch prescribed by a neurologist or by the primary care physician?
It can be prescribed by a primary care physician. It doesn't have to be prescribed by a neurologist.
And what do you suggest people do about financial issues? So if someone's having trouble managing and is very suggestible and has had a couple incidents of very expensive taking advantage of somebody financially, what do you suggest? We can't, I mean, we're by no means incompetent, but what do you do? What do you suggest?
That's a good question, and the expert actually stands right next to you. Ellen is usually the person I turn to if I want to solve a problem like this. In general terms, it would be important to limit or to have a max on a debit card or credit card so that this person cannot spend all their money. It could be that all the phone calls go to voicemail and that we encourage that it does not get picked up unless somebody else is with them. So, I'm sorry, say it again? Right, but often it happens over the phone, right? That somebody becomes a victim of phone solicitation. When it comes to bank transactions, for example, then it would be important to have somebody appointed as a financial power of attorney so that maybe a check has to be co-signed or something like that. So people can work with their bank on that.
Thank you.
Yes, so some of that can be part of normal aging. I personally have struggled with it since I was 20, and some people remember every single name they've ever heard, so some of it is just the way we are. But names, especially somebody's first or last name, is harder to remember because it's kind of a word out of context that doesn't come with any other memory any other memory aids attached to it.
I have a question here.
This is regarding Alzheimer's. Since you mentioned that family history is a big risk factor, if both parents had Alzheimer's, what is the percentage, for want of a better term, that their child or children will develop?
So let me just repeat the question. So, strong family history of Alzheimer's disease increases the risk of an individual's person to have Alzheimer's disease as well. She's wondering what the percentage of somebody, or the risk is of somebody developing Alzheimer's disease when both parents had it. And there's really not a straightforward answer to that, because it really depends at what age they developed it. For example, if both parents developed Alzheimer's disease before they were 65 years old, the likelihood is much higher than if they developed it in their 80s or 90s. So there is no hard and fast number.
I have a question back here. Do you want me to ask or do you want to? Okay. So the question back here is, if you have younger onset of Parkinson's disease, does that affect your propensity to have mild cognitive impairment? Will you more likely have the MCI or dementia?
Right. Can I just clarify the question? Does that increase the risk of having mild cognitive impairment at the time of the diagnosis or just sometime later on in life?
I've had youth onset Parkinson's for quite a few years now, and now I'm developing some MCI concerns. What's the chances of developing dementia? At one time I read that the youth onset was very rare to go to dementia.
That is correct. So not all Parkinson's disease is the same, and not Alzheimer's disease, and not all dementia is the same. Younger Parkinson's patients are less likely to develop it, but Parkinson's patients as a group are at higher risk of developing dementia at some point, usually down the road. And the longer you live with that condition, the higher the risk is eventually. I'll get to you in a moment.
Many, did you want me to go?
Yeah, go ahead.
Many people with Parkinson's, of course, are on levodopa. Is there an effect, either pro or con, in this regard from levodopa, a side effect, or does it limit it or have any positive effect?
So the question is whether levodopa increases the risk of dementia. Is that your question? I think neither, but then again, I'm not the Parkinson's specialist here. That would be a good question for the Parkinson's group, but I don't think that that medication per se increases or decreases the risk of memory problems.
No, I mean, we can see some effects of that the dopamine has on the brain. It's where our reward center is, so we can see some depression, if we don't have enough dopamine, and thus if you have pretty severe depression and some of the, symptoms that you're hearing here, but not that it causes it, and if we were to get you on the appropriate amount of carbidopa-levodopa, would that help eliminate it likely? Some people have kind of a dysregulation syndrome with dopamine as well, that I tend to see anxiety and depression with as well, and can lead to some of these symptoms, but it doesn't cause dementia or lead to dementia. It can, yes. Yeah. He asked if it would affect the anxiety and depression, and I said, yes, it can. And I have another question here.
Does personality play a part in this? For instance, a person who has a personality of being a bully, of always in other words, you don't have compassion, kindness, you don't have gratitude in your personality. Does that, a person that has that type of personality, is that a factor in developing dementia?
That's a good question, but unfortunately, perfectly nice people can get dementia or Alzheimer's disease.
Did you hear it? Okay. Okay, so she said that it's a good question, but unfortunately.
Alan? No. Somebody back there.
So the medications that were just up there,
Yeah, and I don't know how to make them come up there again. Oh, there we go. No, you have to
that's
sign
okay.
it.
Are they effective at any point in dementia, or are they better if they started at the beginning, or like when are they at maximum efficacy? And if you wait a period of time and then start, is it not going to be as effective if you started it early?
That's a good question, and it's still a question that's being debated. So, as I mentioned, these medications are all FDA approved for dementia. They're not FDA approved for the earlier stages like mild cognitive impairment. But still, you wonder whether starting it at a point when the brain is not as affected yet would have a better benefit. But it's never been clearly shown to be the case. What is important, though, that at the very earliest stages, even in early stages of mild cognitive impairment, to make all the other changes that can protect the brain.
Thank
But
you.
if you were going to wait, let's say, half a year or a year, do you lose valuable time? Probably not. But there's really no good data to support that starting it, in the year 2019 would be more effective than starting it in the year 2020.
I have a question here.
Talking about the vascular dementia, I'm just wondering, like, if you've had grandparents or even had a parent, how likely is that one that, or is that one that wouldn't, qualify as far as being passed on or more likely to develop it?
Yeah, that's a very good question. Let me just repeat this. So we talked about the fact that when you have a relative with Alzheimer's disease, your individual risk of Alzheimer's disease is higher. Is that also the case if somebody had vascular dementia? Is your risk of dementia higher? And the answer is not as straightforward. It's probably not directly inherited, but people who have vascular dementia usually have had several strokes or many smaller strokes. And having somebody with strokes in your family also increases your risk of strokes, and that indirectly can also increase the risk for vascular dementia. But that, again, is something that one can work on very aggressively, even at a younger age or at middle age, to be as healthy as possible to prevent those strokes.
I have a question. I'm wondering if a parent has Parkinson's, how directly that affects someone.
I'll let Addie answer that question.
One more time the question. Yeah. So there is genetic relation for Parkinson's. So it can be, but it depends on what genes you have that lead to Parkinson's. So there are actually different genes that, if activated, can cause Parkinson's. Some people, if you're, it usually takes something to activate the gene, whether it be exposure to insecticides, herbicides, something like that, or a viral illness we think maybe could lead to that. It's not 100% known, but yeah, there are some genes that we do inherit, and then if you are exposed to something to activate it, then yes, it does increase your risk. But not as much as you would think. It's a small percentage is my understanding.
We'll definitely do that.
So with regard to dementia, when should you first see a doctor?
The question is, in regards to dementia, when should you first see a doctor? Well, first of all, you should see a doctor every year, period. And very often a good primary care doctor will ask you questions, whether you're concerned about your memory or whether everything at home is going all right. But it's also helpful to bring it up yourself if you're concerned about your memory, and then a primary care doctor can start with some easy and kind of screening questions to see whether there is a sign of dementia, and then can refer you on. So anytime you're worried about your memory, speak up. And you can start by talking to your primary doctor about this.
It's really for you, more or less. With Parkinson's, I've kind of heard or read in some of the research that they indicated that it more comes from the mother. Is that factual?
So she was asking if in Parkinson's disease, does that come more, is it inherited more from the mother? And I don't know the answer to that. I'm not sure that I cannot say yay or nay to that. I'm sorry.
When it comes to Alzheimer's disease, though, having a mother with Alzheimer's disease increases your own risk of Alzheimer's disease slightly more than having a father with Alzheimer's disease. Addie, there's somebody way in the back there.
Okay. Yep.
I wondered if you were kind of diagnosed with Parkinson's like syndrome as a side effect from a medication, and will that kind of syndrome, can that lead to more chance of having dementia?
Yes, so some people have the typical idiopathic Parkinson's disease, and some people will have Parkinson's symptoms related to a medication. And the question is whether that kind of Parkinson's symptoms also increase the risk of dementia. And the answer is probably not as much as the typical Parkinson's disease, but it really depends on the medication that was taken.
Thank you.
Great. Well, thank you very much, Dr. Seeger. Really appreciate it.